Good morning, ladies and gentlemen. Today's lecture is continuation of my previous two lectures. And since the last two lectures, we are discussing various systemic therapies. So this is the part 3 of Principles of Systemic Therapy. And I will also take one more lecture from the same chapter to complete this topic. So let's proceed on. So today we are going to discuss glucocorticoids, which is no doubt one of the most important drugs we use in dermatology. Then we will also be discussing briefly the fumaric acid esters, the hydroxycarbamide, Aprimelast, Tofacitanib, potassium iodide, systemic retinoids, and thalidomide. Glucocorticoids. The glucocorticoids are the family of steroid hormones that have vital immunomodulatory and metabolic functions and are the most frequently used anti-inflammatory agent for the dermatological conditions. Since ages, it is said that if you know how to use a glucocorticoid, you have become a dermatologist. So this has always been a very important weapon in our armory. The term glucocorticoids is often used synonymously with corticosteroids. The principal naturally occurring glucocorticoids with modest glucocorticoid potency is cortisol or hydrocortisone. A number of synthetic systemic glucocorticoids with intermediate potency are the prednisolone, methylprednisolone, and triamcinolone. Prednisolone is the ingredient of delta-cotrol. Methylprednisolone we give in IV drips, called as solomedrol. Then triamcinolone is the popular Canacort. Hydrocortisone is the Solocortif. Then the high potency glucocorticoids are the betamethason, betnisol or betnilone, and dexamethasone, which is trade name as Decadron. The dermatological uses. The licensed indication and off-label usage of glucocorticoids vary widely in dermatology, and they include the bullous dermatosis, connective tissue diseases, vasculitides, neutrophilic dermatosis, eczema, the papillosquamous disorders, and miscellaneous conditions like urticaria and sarcoidosis. Low-dose dexamethasone is used in androgen excess syndrome. Pharmacokinetics. Although glucocorticoids are usually administered orally, there are occasional indications for intramuscular, intravenous, and intralesional administration. The oral glucocorticoids are ideally given in early morning to conform to the natural circadian rhythm of endogenous glucocorticoids. So naturally, in body, high concentration of glucocorticoids is produced in the morning. So ideally, the oral glucocorticoid should be given in the morning to conform to this endogenous secretion. The traditionally prednisolone, which is the biologically active metabolite of prednisone, which is marketed as delta-cortical, is the favored oral glucocorticoid for dermatological purpose, although betamethasone, dexamethasone, deflazacort, and hydrocortisone and methylprednisolone can also be given orally. The intramuscular administration of glucocorticoids has advantages of guaranteed effect in an unreliable patient and also avoid the potential GI side effects. So if you are not sure if a patient is going to take the delta steroids as prescribed, the oral steroid as prescribed, so you can switch over to intramuscular preparation. However, the intramuscular glucocorticoids cause fat atrophy at the injection site and menstrual irregularities. Triamcinolone acetonide, popularly known as the Canacort or Tricort, is the favored intramuscular used glucocorticoids. Then intravenous administration of glucocorticoids is usually given in pulses on inpatient basis. In situation where it is desirable to bring very serious steroid responsive condition under rapid control. The methylprednisolone is usually given in an intravenous route. The risks particularly associated with intravenous pulse glucocorticoids include sudden death of presumed cardiac origin, secondary to acute electrolyte shift, cardiac arrhythmias, potentially life-threatening anaphylaxis, gastric erosion, and sepsis. So, this intravenous pulse glucocorticoid therapy should always be done on inpatient basis by a trained and seasoned dermatologist. Pharmacokinetics. Synthetic glucocorticoids are readily absorbed from the small bowel after oral administration, and peak plasma concentration occur after 1 to 2 hours. We are talking about the delta cortical. They are significantly protein bound in the circulation, called as the cortisol binding globulin or transcortin, as well as albumin, and become widely distributed in body tissues and may also cross the placenta. Glucocorticoids are metabolized primarily in the liver, and biological half-life of glucocorticoids vary. It is 8 to 12 hours for the short-acting glucocorticoids like hydrocortisone and cortisone, 24 to 36 hours for intermediate acting like prednisolone or methylprednisolone or triamcinolone, and 36 to 54 hours for long-acting glucocorticoids like betamethasone and dexamethasone. Pharmacodynamics. The synthetic glucocorticoids have been developed primarily as an anti-inflammatory agent for treatment of conditions which are unresponsive to the natural anti-inflammatory process. They are known to act within the nucleus at genomic level, but also have non-genomic effects. Both lipophilic glucocorticoids, being lipophilic, the glucocorticoids cross the plasma membrane into the cytoplasm of the cells with ease, and they bind to the cytosolic glucocorticoid receptors known as the CGCR. On binding, the glucocorticoids and the receptor complex passes into the nucleus. There, the complex binds to specific DNA binding sites, from where it modifies the transcription of the gene. So this is how the glucocorticoids act. Depending on the target gene, transcription is either activated known as trans activation or inhibit it. In addition to its DNA binding effect on transcription, the glucocorticoids and the receptor complex also prevent the binding to their target gene of a variety of natural transcription factors, such as activator protein 1, nuclear factor of activated T cell NFA2, that result in reduced expression of many immunoregulatory and pro-inflammatory proteins. This process is called as the trans repression. Glucocorticoids impair the TCR signaling and consequently T cell cytokine production, proliferation, and differentiation. So these all are anti-inflammatory effects. In addition to these desirable anti-inflammatory properties, in context of treating the disease states, the enhanced effect of synthetic glucocorticoids on gene transcription result in number of undesirable metabolic consequences. These include increased carbohydrate production by enhanced metabolism of endogenous protein from the bone, muscle, skin, and blood vessels, and on fat metabolism with associated peripheral insulin resistance. It has long been assumed that unwanted effects of prolonged treatment with glucocorticoids are largely the result of trans activation, while the beneficial anti-inflammatory effects are the result of trans repression. This is a very important table in which the dose equivalence of various corticosteroids is mentioned. Why this table is important? Because you may have to shift from some long-acting to intermediate-acting or short-acting steroid. So beta-methasone is usually available in 0.5 milligram tablet. So if we consider it like that, so usually the two tablets are equal to 10 milligram of prednisolone, that is 2 tablets of delta cortical 5 mg. And if we compare it with the triamcinolone usually is available as 40 mg. So by giving a 40 mg triamcinolone, we mean that it is equivalent to the 5 times of prednisolone, that is 50 mg delta cortical. So this table will help you in shifting from one corticosteroid to the other corticosteroid. The potential adverse effects of corticosteroids, the glucocorticoid effect. The common metabolic glucocorticoids effect are hyperglycemia and development of diabetes if given for a prolonged period of time. Then if a patient is already diabetic, then the diabetic control deteriorates. It also causes dyslipidemia, hypertriglyceridemia, and hypercholesterolemia. Glucocorticoids causes weight gain by mainly increasing the appetite. It also causes the menstrual irregularity and Cushingoid features with lipodystrophy, moon face, buffalo hump, and central obesity. The glucocorticoids will also have a little bit of mineralocorticoid effect, which manifests as hypernatremia and water retention, hypertension and weight gain, hypokalemia and hypocalcemia. The cutaneous side effects of long-term glucocorticoids include purpura, bruising, stria, dermal and epidermal atrophy, and telangiectasias because of cutaneous thinning. Steroid acne and aggravation of rosacea or rosacea-like syndrome is also initiated. There is impairment of wound healing. It may result in hirsutism, fat atrophy with injected glucocorticoids, then promotes cutaneous infections like staph or herpetic, and hyperhidrosis. The other adverse effects include bone. It causes osteoporosis and growth impairment in children. On gastrointestinal tract, it may result in peptic ulceration, bowel perforation, fatty liver, gastroesophageal reflux. Psychiatric, it causes psychosis, euphoria, depression, agitation, insomnia, nightmares, suicidal ideation. Ocular, causes ocular hypertension, glaucoma, cataract, neuromuscular weaknesses, muscular weaknesses, intracranial hypertension, and it may result in TB and other opportunistic infection reactivation. So these side effects are particularly seen with high or supraphysiological doses in a long-term regimens. Short courses, which comprises of 2 to 3 weeks of glucocorticoids, are generally relatively safe. Hydrocortisone has significant mineralocorticoid activity. So if we are putting a patient on solocortef, you may expect hypertension, water retention, weight gain, and other effects like that. Glucocorticoids or intermediate potency have some and some with high potency have negligible mineralocorticoid effects. Malignancy. The development of immunosuppression related malignancies such as lymphoma, squamous cell carcinoma, and Kaposi sarcoma is very uncommon when glucocorticoids are used in isolation. Then a very important phenomenon which is called as the steroid withdrawal syndrome. Withdrawal of glucocorticoids may idiosyncratically associated with signs and symptoms of adrenal insufficiency. This syndrome occurs when glucocorticoids in high doses is suddenly stopped. And the symptoms include fever, anorexia, nausea, vomiting, lethargy, fatigue, weakness, malaise, emotional lability, depression, myalgias, arthralgias, headache, abdominal pain, skin peeling, influenza-like syndrome, and weight loss. So we have the symptoms of GI like nausea, vomiting. Then we have an anorexia. We have symptoms of weakness like lethargy, fatigue, malaise. Then we have the psychological symptoms like emotional lability, depression, and skin symptoms like peeling and headaches and weight loss. In addition, there is postural hypotension, hyponatremia, and hyperkalemia. The possible explanation of these symptoms are by increased circulating levels of pro-inflammatory cytokines like interleukin-6, tumor necrotic factor alpha, and interleukin-1b. The treatment is to reinstitute the glucocorticoid therapy, followed by more gradual tapering of the dose. Adrenal suppression, another important phenomenon, which all the glucocorticoid prescriber must know. Endogenous cortisol production is regulated by a homeostatic mechanism from hypothalamic pituitary axis. Synthetic glucocorticoids suppress this hypothalamo-pituitary axis and abolish the endogenous cortisol production by adrenals, resulting in potential acute adrenal insufficiency or Addisonian crisis if glucocorticoids is suddenly stopped. So what I mean to say that heavy doses of glucocorticoids inhibit the hypothalamic pituitary axis or the homeostatic mechanism for glucocorticoid endogenous production from adrenals. And this is taken up by the synthetic or orally given steroids. So if we don't reduce the steroid gradually and we suddenly stop, then because of this adrenal suppression, we will have the steroid withdrawal symptoms. But if steroids are reduced gradually, then gradually and slowly, the naturally or endogenous corticosteroid production will increase and will take up its normal usual role. It can take many months for normal adrenocortical response to fully recover, and vulnerability to stress may last for years or more. If the stress is given, then it will take many months to recover. Then glucocorticoids in divided doses or at times other than the morning are more likely to induce hypothalamic pituitary axis suppression. Alternate day glucocorticoid reduces the risk of hypothalamic pituitary axis suppression. So the ideal way to give corticosteroids is to give once a day morning dose. If you split the dose in 2 to 3 doses, then there are more chances of hypothalamic pituitary axis suppression than the normal dose. However, if you are giving the steroid for a long period of time and you are giving a large number of tablets, then it is better to split the dose, but never ever reduce the steroid abruptly. The early morning cortisol level and 24 hours urinary cortisol level both provide a measurement of basal hypothalamic pituitary axis function for a patient on glucocorticoids, or short synectin stimulation test is a measure of stress responsiveness of the adrenals. Glucocorticoids taken in daily dose of more than 40 mg for more than 1 week or lesser dose for more than 3 weeks should be tapered gradually. 40 mg means we are giving 8 tablets. So if the patient is given 4 plus 4 or 8 tablets for 1 week, then it should be tapered. Anything lesser than that can be stopped. Intercurrent illnesses, infection, surgical procedures, or trauma requires temporary increase in glucocorticoid dose if a prolonged glucocorticoid course is recently been completed. So why is it so? Because of adrenal suppression, the body will be unable to produce the excess called glucocorticoids, which is required for these stressful episodes. So hence you need to give some oral steroid to counter this stress. Anesthetist must know if the patient is taking or has been taking a glucocorticoids within 3 months of surgery. Patient on long-term glucocorticoid therapy should carry a steroid treatment card with them all the times. Acquired resistance. The therapeutic response to glucocorticoids in chronic inflammatory disorders may be compromised due to resistance or insensitivity to glucocorticoids. The precise mechanism is downregulation of glucocorticoid receptor expression and inhibition of these receptor translocation by pro-inflammatory cytokines. As a consequence, high dose of glucocorticoids is required to maintain the disease control with increased risk of adverse effect. So you never know which patient is having the resistance to glucocorticoids. So it is just by giving the glucocorticoids, you will come to know the patient is poor responsive or good responsive. Infections. Prolonged course of glucocorticoids increase the susceptibility to infection and may mask signs of infection, particularly septicemia and tuberculosis. Glucocorticoids predisposes to severe chickenpox and measles if patient is not already immune. Fungal or viral ocular infection may be exacerbated, as may be the amoebiasis and strongyloidiasis. Then cautions. Bone protection. Glucocorticoids induce osteoporotic fractures, and this is a real risk with long-term therapy. Even in low dosage, and monitoring with bone mineral density DEXA scan is advisable in patient on long-term glucocorticoid therapy. Anyone more than 3 months should have their DEXA scan. Preventive measures include calcium and vitamin D supplements and biphosphonate therapy, together with lifestyle advice, including the weight-bearing exercises, smoking cessation, avoiding excess alcohol, and initiating long-term glucocorticoid therapy, and when initiating long-term glucocorticoid therapy to limit the exposure to osteoporosis. GI protection. Although controversial, the prophylactic administration of proton pump inhibitor or H2 antagonist should be considered whenever a high dose of glucocorticoid is prescribed. Psychiatric reactions. Glucocorticoid should be prescribed with caution in patients with personal or family history of psychiatric disorders. Pregnancy. Glucocorticoids increase the risk of spontaneous abortion and stillbirth, hence should not be given in high doses in first trimester of pregnancy, and the possibility of the fetal hypothalamic pituitary axis suppression should be considered when it is given to mothers close to delivery. General caution. Care should be taken while prescribing glucocorticoids to children, adults, elderly, pregnant, diabetics, hypertension, osteoporotic, raised intraocular pressure, patient with history of peptic ulcer, diverticulitis, recent bowel anastomosis or tuberculosis, and if there is any hepatic or renal impairment. Contraindication. The systemic infections and vaccination with live virus should be avoided in patients taking glucocorticoids. Drug-drug interaction. There are large number of potential interactions between systemic glucocorticoids and other drugs. The glucocorticoids antagonize the hypotensive effect of ACE inhibitors, alpha and beta blockers, calcium channel blockers, and the antagonizes the effects of hypoglycemic agents and diuretics. So if these agents are to be prescribed or are being prescribed with oral corticosteroid, then their doses may be increased. Then there is increased risk of GI bleeding if given with NSAIDs. If given with oral contraceptives, it increases the plasma concentration of steroids. And if given with anticonvulsants, the effect of anticonvulsants is reduced. Pre-treatment screening. If a short course up to 3 weeks is planned, it is reasonable to establish where there is a coexisting condition that might be influenced by glucocorticoids, such as diabetes, psychosis, glaucoma, infection, or peptic ulcer. If extended treatment is anticipated, baseline assessment of blood pressure, the weight, serum electrolytes, fasting glucose, and fasting lipid should be undertaken. Also, Montu test and chest X-ray. Baseline ophthalmic examination for cataract and ocular hypertension should also be considered. The dosage and the regimen. Oral administration. It is reasonable to consider commencing prednisolone at a starting dose of 0.5 milligram per kg or 1 milligram per kg, depending upon the skin condition, in a single morning dose. A single daily dose is less likely than divided doses to cause adverse effects. and morning dose is less likely to cause suppression of hypothalamic pituitary axis. Then intramuscular administration. The typical regimen for intramuscular triamcinolone is 40 to 80 mg, 2 to 3 times an year. Pulse intravenous administration. The typical regimen for inpatient pulse IV therapy with methylprednisolone is either 500 or 1000 milligram, approximately 10 to 15 milligram per kg per day, over 60 minutes for 3 to 5 consecutive days, with continuous cardiac monitoring and daily measurement of electrolytes and glucose levels. Thereafter, oral prednisolone and non-steroidal immunosuppressives may be required to maintain the therapeutic effect of pulse intravenous therapy. Tapering steroid dosage. Generally, as soon as there is adequate disease control, consideration should be given to taper the long-term glucocorticoids to minimum effective dose in order to minimize the risk of side effects. When withdrawing glucocorticoids, it's reasonable to attempt to reduce the dose rapidly to a physiological level, that is 7.5 milligram prednisolone daily or equivalent, and thereafter by more gradual reduction. So the general rule is that, for example, if a patient is on more than 10 tablets, then once the disease control is achieved and there is no new lesion, you can reduce 1 tablet weekly until we reach to about 20 milligram. And after that, you can reduce 1 tablet after 2 weeks or 3 weeks and till the physiological dose is reached. In supraphysiological dose of glucocorticoids on long term, if a supraphysiological dose of glucocorticoids is required in long term, it's better to give it an alternate day regimen rather than daily, which is less likely to affect the hypothalamic pituitary axis. Now, the example for this is that, for example, a patient requires 40 milligram of delta cortical daily. It's better to give the patient 80 mg on alternate days rather than 40 mg daily. Monitoring. At each visit, specific inquiries should be made for the side effects like blood pressure and weight, which should be recorded, and serum electrolytes, fasting glucose, and lipid should be measured. An ophthalmic examination every 6 to 12 months is recommended. Neutrophilia frequently occur with glucocorticoids, which should not be of any particular problem. Depending on the therapeutic response and likely duration of therapy with glucocorticoids, active consideration should be given to steroid-sparing strategies. Way forward. For the future enhancement of risk-benefit ratio of glucocorticoids is possible by the targeted delivery of glucocorticoids. These are the long circulating liposomal glucocorticoids, and by combining glucocorticoids with synergistic anti-inflammatory moieties like nitric oxide or modified release of glucocorticoids to conform to the circadian rhythm, which is called as the chronotherapy. So these all are the future of glucocorticoids. Novel non-steroidal drugs like Segra, the selective GCR agonist, and Segram's selective GCR modulators may have the anti-inflammatory properties of conventional glucocorticoids with fewer side effects. So these drugs will soon be available for the general use. Now we have reached to the second drug of today's lecture, that is the fumaric acid esters. Fumaric acid esters are effective in moderate to severe plaque psoriasis, but appear ineffective in psoriatic arthritis. They act by decreasing the Th1 cytokine production including interleukin 12 and 23, and correspondingly increase the Th2 cytokines, that is interleukin 4. They also alter the Langerhans cell function and subsequent decrease in tumor necrotic factor alpha and interleukin 8 levels. Commercially, it is available as the Fumaderm, which contains methyl fumarate and is given according to the gradually increasing dose to a maximum of 240 milligram TDS. Fumaderm is given for 16 weeks and has a pronounced improvement in PASI score between 50% to 80%. Fumaderm causes gastrointestinal upset like diarrhea. Flushing is seen in 30% of patients which respond to aspirin or antihistamine, and a transient eosinophilia may develop, but this may cause lymphopenia in significant number of patients. So the current guidelines suggest dose reduction if lymphocyte count decreases below 0.5 into 10 to the power 9 per liter. Tolerance develops in majority of patients, allowing the dose escalation. Despite the immunosuppressive nature of fumaric acid esters, there are a few reports of opportunistic infections, like reactivation of TB, progressive multifocal leukoencephalopathy, and Kaposi sarcoma. Active infections must be excluded before starting this therapy, as well as caution should be excised while using it in existing systemic malignancies. Fumiderm may also cause proteinuria. Most cases are stable and do not require the dose reduction or cessation. Despite recognized effects on renal function, progression to renal failure is not reported, and guidelines recommend that renal failure is a contraindication to fumaric acid therapy. The toxicological studies have shown that fumaric acid esters are neither teratogenic nor have a mutagenic potential. Nonetheless, conception for men and women, pregnancy and breastfeeding are all contraindicated. Recent studies suggest that caution must be excised when fumaric acid esters are used with methotrexate, psoralen, retinoids, cyclosporin, immunosuppressant, cytotoxic, or any other drug with known nephrotoxicity. Full blood count, renal and liver function, and urine analysis for protein must be checked monthly during dose escalation, then bi-monthly once the therapeutic dose is established. Now, another drug which is less commonly used is the hydroxycarbamide or hydroxyurea. It's indicated predominantly in lymphoproliferative disorders and for conditions with high risk of thromboembolic complications like polycythemia rubra vera and essential thrombocythemia, and occasionally in recalcitrant chronic plaque psoriasis. Dose prescribed is 0.5 to 1.5 milligram daily. There does not appear to be any benefit increasing the dose beyond 1.5 gram. Long-term satisfactory control can be achieved in patients on hydroxycarbamide for up to 10 years. It is cheap and appears to be well tolerated. The drug can cause dose-dependent bone marrow toxicity and has a narrow therapeutic window. It is excreted via kidney, so caution should be excised in patients with renal impairment. It raises the mean corpuscular volume on full blood count test. Hydroxycarbamide is used in the treatment of HIV infection and a suitable choice for systemic treatment in psoriasis in HIV. It is reported to be associated with increased incidence of actinic keratosis and SCC. The dose regimen. When used for cutaneous disorders like psoriasis, initial dose is 1 gram once a day. Depending upon the clinical response and hematological parameters, this can be gradually increased to 2 gram, but not more than that. Monitoring is full blood count is checked weekly for first month, then fortnightly for 3 months, and monthly for further 3 months. Dose adjustment or temporary cessation of therapy should be considered if there is some degree of myelosuppression. Monthly electrolyte, creatinine, and liver function reducing to 3 to 6 months if stable. Then a very popular new drug in dermatology in Pakistan is Aprimelast. Aprimelast is an oral inhibitor of enzyme phosphodiesterase 4, which plays an important role in the treatment of chronic inflammation associated with psoriasis. Aprimelast is inhibitor of phosphodiesterase 4 and prevent the degradation of cyclic AMP to AMP, suppressing the production of pro-inflammatory cytokines like tumor necrotic factor alpha, interleukin 17, interferon gamma, and promoting the production of anti-inflammatory mediators like interleukin 10. So all these effects are beneficial effects for chronic plaque psoriasis. It is recommended, the recommended daily dose of Aprimelast is 30 milligram BD. It's available in 30 milligram tablet. To reduce the GI symptoms, the recommended way to start the Aprimelast is 10 mg OD on day 1. The tablet is cold and it can be broken into 3 parts. While few of the pharmaceutical companies are marketing the initial pack with the 10 mg tablet. While if such kind of pack is not available, then you have to break the tablet into 3 parts. So the day 1, 10 mg, day 2, 10 mg morning, 10 mg evening, day 3, 10 mg morning and 20 mg evening, day 4, 20 mg morning and 20 mg evening, day 5, 20 mg morning and 30 mg evening, and from day 6, 30 mg twice a day. Aprimelast is well tolerated. No monitoring or testing is required. This is the most important part of Aprimelast. I don't know of any of the systemic drugs which are used in psoriasis which are free of this monitoring. The most commonly reported adverse effects are diarrhea, nausea, upper respiratory infection, and headache, which is seen in 0.8%. Aprimelast should be used during pregnancy only if the benefit justifies the potential risk to the fetus. Summary: Aprimelast is safe and effective systemic treatment for moderate to severe psoriasis. It is much less expensive than the biologics. The price is also low, much lower than Tofacitanib. Minimum duration of treatment is 3 months. No laboratory monitoring is required. Dose reduction in renal impairment, but no dose reduction in liver impairment. There is no FDA approval for patient under 18, pregnant and lactating women. Patient under 18 may be tried, but it is better to avoid in pregnancy and lactation. The main side effects is diarrhea, nausea, and headache. Then another popular drug, which is gaining popularity because many pharmaceutical companies are preparing this drug nowadays. And every now and then we see one person bringing a new salt in the market. Tofacitanib is inhibitor of enzyme genus kinase 1 and genus kinase 3, popularly known as the JAK inhibitors. It interferes with the JAK-STAT signaling pathway that transmits extracellular information into the cell nucleus, influencing the DNA transcription. Tofacitanib is a small molecule but is not a biologic. and it is known as a small molecule. Tofacitanib and other JAK inhibitors show potential to broaden the treatment option of psoriatic arthritis and other inflammatory conditions. The most common side effects of tofacitanib is headache and diarrhea. Other effects include the tiredness, dizziness, tachycardia, dyspnea, nausea, vomiting, loss of appetite, abdominal pain, jaundice, and risk of pulmonary embolism. Serious allergic reactions are rare. Tofacitanib can cause serious infections like tuberculosis, bacterial infection, viral, fungal, and opportunistic infections. Laboratory workup before prescribing tofacitanib. Following investigations are required: blood complete picture, liver function, renal function, PT, PTTK because it can cause coagulation, ASO titer, MON2 and serum gold quantiferon, HIV and hepatitis B and hepatitis C, and add ECG here. Usual dose is 5 mg twice a day. Tablet is taken orally with or without food. The next drug to be discussed is known as the ponesimod. Ponesimod is a modulator of sphingosine 1-phosphate receptor and prevents T lymphocyte migration from secondary lymphoid tissue into circulation. PASI 75 at 16 weeks in 46% of individuals is achieved. 48.11% of patients treated with ponesimod 20 mg or 40 mg orally daily, respectively. There is an increased incidence of heart block and liver abnormalities with these drugs. Potassium iodide. Potassium iodide is used principally as an emergency treatment for hyperthyroidism following exposure to nuclear radiation. The dermatological uses of potassium iodide, it is an inexpensive brand and used in treatment of cutaneous porotrichosis, erythema nodosum, subacute nodular migratory panniculitis, nodular vasculitis, Sweet syndrome and Behçet syndrome, and pyoderma gangrenosum and erythema multiforme. Pharmacological properties. Potassium iodides are given as drops of saturated solution of potassium iodide known as SSKI, but is most conveniently given in tablet form. Pharmacokinetics: well absorbed orally and distributed to thyroid and to lesser extent to salivary gland, breast, choroid plexus, and gastric mucosa. It crosses the placenta and found in breast milk. It is excreted predominantly in urine, and a small amount is excreted in sweat and in feces. Pharmacodynamics: the mechanism by which potassium iodide exerts its anti-inflammatory effect is unknown, although there is evidence that it has the detrimental effect on neutrophil chemotaxis and generation of neutrophils for pro-inflammatory oxygen intermediates. The potential adverse effects of potassium iodide. The Wolff-Chaikoff syndrome. It is the inhibition of organic binding of iodine in normal thyroid gland by excess iodine in potassium iodide. This blocks the thyroid hormone synthesis and predisposed to temporary hypothyroidism. Resolution takes several weeks and thyroid replacement therapy is needed. Then Jod-Basedow phenomena. Therapeutic administration of potassium iodide to a person with thyroid dysfunction lacking the pituitary control, such as Graves' disease, may cause a significant exacerbation of hyperthyroidism rather than hypothyroidism. Then potassium toxicity. It is the symptom of hyperkalemia that include fatigue, confusion, palpitation, muscle weakness, numbness, and tingling of extremities. Other adverse effect of hyperiodism is silidinitis, particularly parotid and submaxillary gland, hypersalivation, metallic taste like halitosis, burning sensation in mouth, coryzal symptoms or headache, gastric irritation, diarrhea, and nausea, urticaria, angioedema, acneiform pustulation, and iododerma. Contraindication. It is contraindicated in pregnancy with known hypersensitivity to iodine associated with fetal malformation and may cause hypothyroidism in fetus. Caution should be excised when giving to patient with thyroid and cardiac disorders and condition associated with hyperkalemia and active tuberculosis. It may exacerbate dermatitis herpetiformis, pustular psoriasis, and hypocomplementinemic vasculitis. Drug-drug interaction. Potassium iodide may interact with antithyroid drug with lithium, amiodarone, and sulfonamide to cause hypothyroidism. Potassium-sparing diuretic and ACE inhibitors cause hyperkalemia. Pre-treatment screening. Specific inquiries should be made regarding thyroid disease. Suspicion of thyroid disease should prompt checking of thyroid functions. Baseline check of electrolyte and urea should be undertaken. Dose. For dermatological condition, reasonable initiating dose is 300 mg, increasing to 900 mg daily depending upon the disease activity and tolerability. Monitoring. TSH level checked 1 monthly after initiation of therapy to exclude iodine-induced hypothyroidism. And it is reasonable to monitor the potassium level as well. Then next, drugs to be discussed are the systemic retinoids. There are 3 generations of dermatologically useful systemic retinoids. The first generation is the non-aromatic retinoid, which is represented by isotretinoin or L-tretinoin. These are non-aromatic. Then monoaromatic retinoids include acitretin, which is a metabolite of etretinate and has now replaced completely the etretinate. Then the third kind is the polyaromatic group, and these retinoids include bexarotene. Non-aromatic, isotretinoin and L-tretinoin, then monoaromatic acitretin, and polyaromatic bexarotene. Dermatological uses. Isotretinoin is licensed for the treatment of severe acne, resistant to adequate course of standard therapy. Off-label use include rosacea, hidradenitis suppurativa, and dissecting cellulitis of the scalp. L-tretinoin is a product licensed to treat severe chronic hand eczema, and FDA has approved it for the cutaneous lesions of Kaposi sarcoma as a topical treatment. Acitretin is licensed for the treatment of severe psoriasis, resistant to standard therapy, for palmoplantar pustular psoriasis, inherited ichthyosis, and Darius disease. Acitretin off-license use as chemoprophylaxis to reduce the risk of actinically induced non-melanoma cutaneous malignancy. Bexarotene is indicated for the treatment of cutaneous manifestations of advanced cutaneous T-cell lymphoma. Retinoids have also been used off-license to treat pityriasis rubra pilaris, lupus erythematosus, and lichen planus. The pharmacological properties. All systemic retinoids are administered orally. No intravenous or intramuscular dose. Absorption is from the gut into intestinal mucosal cell, passage to liver, intracellular processing by hepatocytes, secretion into the blood, where it's bound to albumin, and finally uptake by nucleus of the targeted cells. This involves a sequence of intracellular transport proteins that include the cellular retinol bonding proteins, plasma retinol binding proteins, and cellular retinoic acid binding proteins. Being taken with food or milk enhances the bioavailability, so should be taken with food cross the placenta and secreted into the breast milk. Retinoids are metabolized by isomerization and oxidation by enzymes of cytochrome P450 system and biliary and renal elimination. The elimination half-life of retinoids vary, with that of L-tretinoin up to 10 hours, isotretinoin 20 hours, and acitretin 50 to 60 hours. After cessation of treatment, isotretinoin, bexarotene, and L-tretinoin normal physiological levels are reached within 2 weeks. Acitretin is cleared from the body in 1 month of stopping the therapy, and adequate contraceptive precaution are necessary for up to 2 years. Pharmacodynamics. The complex process of retinoid signaling involved 2 families of retinoid nuclear receptors, the retinoic acid receptor RAR and retinoid X receptor RXR. Isotretinoin and acitretin acts as ligands for the RAR receptors. Bexarotene is the ligand for RXR receptors, and L-tretinoin is a pan-agonist for both RAR and RXR receptors. In addition to this genomic action, retinoids also have the non-genomic effects, in particularly retinoylation and post-translation modification of certain proteins, including cytokeratins. Potential adverse effects. The teratogenicity. Fetal exposure to retinoids in early pregnancy puts at risk the normal neurological, ocular, cardiovascular, and renal development, as well as that of pulmonary system, skeleton, pancreas, and the limbs. Administration of retinoids men during the first trimester may cause craniofacial deformities like cleft palate and external ear malformation, central nervous system abnormalities like hydrocephalus, microcephaly, and cerebellar malformation, heart defects like tetralogy of Fallot, transposition of great vessels and septal defects, and abnormalities of thymus and parathyroid gland in up to 50% of pregnancies, with increased number of early and late stillbirths. There appeared to be a negligible risk of retinoid-induced embryopathy in fetus fathered by men taking systemic retinoids. So, if a male is taking retinoid, then there is no risk to the child born, while if a female is taking retinoids, then there are so many side effects. The psychiatric effects, they include depression, suicidal ideation, personality disorders. Majority of cases relate to isotretinoin for treatment of acne, as per se, which is also, acne is already associated with anxiety, low self-esteem, social phobic disorders, depression, and even pseudo-ideation. So, all these effects may get aggravated. However, the majority of retrospective and prospective clinical trials have failed to prove the association between oral isotretinoin and psychiatric symptoms. The possible mechanisms involving isotretinoin is that it crosses the blood-brain barrier and modifies the expression of a variety of genes in the limbic system, hippocampus, in regulation to mood and emotion. Severe and frequent headaches may be a warning for retinoid-induced depression. It's not clear whether patients with pre-existing history of psychiatric problem are at increased risk, but oral isotretinoin therapy should not automatically be refused in such patients. Ocular side effects. Dry, irritated eyes caused by blepharoconjunctivitis, occasionally complicated by bacterial infection, results from retinoid-induced alteration in conjunctival epithelium and decrease meibomian gland secretion. These problems is alleviated by artificial tears. Retinol toxicity, impair the night vision, is a potential adverse effect of retinoids, and it persists for many years. The gastrointestinal effects, particularly of isotretinoin, is implicated as a cause of inflammatory bowel disease, both ulcerative colitis and Crohn's disease. Mild gastrointestinal upset is relatively common. Then musculoskeletal. Vitamin A toxicity results in hyperostosis, particularly in diffuse interstitial skeletal hyperostosis or DISH. The premature epiphyseal closure, calcification of tendons and ligaments, and lower bone mineral density. The possible rare side effects include rare side effect of premature epiphyseal closure should be considered in pre-adolescent children. Myalgia is a common side effect. Neurological transient headaches are common, but very occasionally oral retinoids may cause benign intracranial hypertension known as the pseudotumor cerebri, which is associated with nausea, vomiting, visual disturbance, loss of vision, especially if isotretinoin is used concomitantly with oral tetracyclines. So this is a big no, that never combine tetracycline with isotretinoin or any other retinoids. Mucocutaneous. Dryness of skin and mucous membrane, especially the nasal lining, the vermilion of the lip, and conjunctiva is very common and is dose-related. It is associated with pruritus, facial erythema, impetiginization, and skin fragility. Epistaxis can be troublesome. Emollient therapy is usually effective. Telogen effluvium, nail fragility, onycholysis, and photosensitivity are occasional complications. Isotretinoin-induced pyogenic granuloma-like lesions can arise as well. Endocrine. Bexarotene and L-tretinoin may both cause central hypothyroidism, and monitoring of this adverse effect is essential. Hyperlipidemia, hypertriglyceridemia, and cholesterolemia is common, particularly with bexarotene, and require monitoring during retinoid therapy. Management of modest dyslipidemia involves dietary modification and increased physical activity and weight control. This hyperlipidemia is reversible on discontinuation. Hepatotoxicity. Retinoid-induced elevation of liver transaminases is common, but of little clinical significance. So severe hepatitis is rare and probably idiosyncratic. Hematological side effects. Neutropenia is common laboratory observation with isotretinoin and bexarotene, and isotretinoin may result in platelet abnormalities. Drug-drug interaction. Tetracycline increases the risk of benign intracranial hypertension, already explained. Alcohol increases the half-life. Methotrexate toxicity is increased if combined with acitretin. Contraindication. Oral retinoids are contraindicated in women who are pregnant or breastfeeding, women of childbearing potential, patients receiving concomitant treatment with tetracycline, patients who are hypersensitive to retinoids. Relative contraindication are renal and hepatic insufficiency and severe hyperlipidemia. Caution. Patients should not donate blood for at least 1 month after stopping the treatment. Thereafter, in case of isotretinoin and L-tretinoin, but 6 months after stopping acitretin. Sun protecting mechanisms must be used. Retinoids affect blood glucose control in diabetes. Pre-treatment screening. Women of childbearing potential should receive explicit counseling on teratogenicity of retinoids and either adopt birth control measures or abstain from coitus. Pregnancy should be excluded prior to commencing the retinoid therapy, and pregnancy avoided 1 month for isotretinoin and L-tretinoin and bexarotene, and 2 years for acitretin. Pre-laboratory tests include full blood count, LFTs, RFTs, and full fasting lipid profile. L-tretinoin and bexarotene it is necessary to monitor the thyroid functions as well. Dosage. Standard dose is different for different kind of retinoids. Liver function test and fasting lipid profile, occasionally renal function test and full blood count is monitored monthly for 3 to 6 months, then 3 monthly. Thyroid function should be monitored in patient receiving L-tretinoin and bexarotene. Special inquiries about adverse effects, particularly those related to mood and vision. And patient report restricted mobility and bone pain should be given relevant radiological investigations. The last drug to be discussed today is thalidomide. It's a pharmacological breakthrough in early 1960 as a sedative and antiemetic drug for pregnant women, but received a big setback when babies were born with limb defects, known as the phocomelia, and the internal deformities in the children. Its subsequent reinvention as a useful therapeutic agent with potent immunomodulatory and anti-inflammatory and anti-angiogenic and anti-neoplastic properties has seen it licensed as a component of first-line treatment for myeloma and for erythema nodosum leprosum. The dermatological uses. It is off-license use in nodular and actinic prurigo, in cutaneous lupus erythematosus, aphthous stomatitis, Behçet disease sarcoidosis, graft versus host disease, Langerhans cell histiocytosis, and cutaneous manifestation of advanced HIV and Kaposi sarcoma. Pharmacological properties. Thalidomide is available as capsule containing 50 mg of thalidomide. Pharmacokinetics. It is lipid soluble. Peak plasma level is reached in 2 to 6 hours. There appears to be a hepatic metabolism involving cytochrome P450. Half-life is 9 hours. Excretion is predominantly non-renal, and it readily crosses the placenta. Pharmacodynamics. Thalidomide affects both cellular and humoral immune response, inhibit neutrophil and monocyte phagocytosis, neutrophil chemotaxis, inhibit the production of a variety of inflammatory cytokines like interferon gamma, interleukin 12, interferon alpha, and interleukin 12. There is evidence to support its teratogenic effects caused by reduced expression of fibroblast growth factor 8, that is an essential regulator of limb development, consequent to binding of thalidomide to cereblon, a ubiquitously expressed E3 ligase protein. Pharmacogenetics. There is recent evidence that the risk of developing peripheral neuropathy is determined by polymorphism in gene governing the repair mechanism and inflammation in peripheral nervous system. So there are two potential adverse effects, the teratogenicity and peripheral neuropathy. Teratogenicity, already explained, causes the phocomelia, congenital heart defects, ocular and oral malformation, urological abnormalities, autism, mental retardation. Critical exposure is between 20 to 36 days after conception. Then peripheral neuropathy. Peripheral neuropathy is very significant adverse effect of thalidomide, occurs in 20 to 55% of the patient, with women and elderly at the greatest risk. Peak incidence in first year of treatment. There is symmetrical, mainly sensory, length dependent axonal polyneuropathy with reduced sensory nerve action potential, SNAP. It presents clinically as symmetrically painful paresthesias of hands and feet, sensory loss, muscle weakness and cramps, and signs of pyramidal tract and carpal tunnel. Recovery tend to be slow and often incomplete, and neurotoxicity is progressive even when thalidomide therapy is withdrawn. Other adverse effects of less significance are venous and arterial thrombosis, hypothyroidism, hypo and hyperglycemia and hypocalcemia, blood effect like anemia, neutropenia, lymphopenia, thrombocytopenia, skin conditions like erythroderma, Stevens-Johnson's and TEN, hypersensitivity reactions, drowsiness, dizziness, depression, confusion, anxiety, anorexia, intestinal obstruction and perforation, dry mouth, constipation, bradycardia, decreased libido, and xerosis, pruritus. Contraindication, absolutely contraindicated during pregnancy, and individuals with known sensitivity, avoided in breastfeeding mothers. Caution, women of childbearing potential receiving thalidomide must practice strict contraception. Men whose sexual partner are women of childbearing age should use condoms, as thalidomide is secreted into the seminal fluid. It is relatively contraindicated in patients with existing peripheral neuropathy or other neurological disorders, or if there is significant renal or hepatic impairment, congestive cardiac failure, hypertension, hypothyroidism, GI disease, and increased risk of thrombosis. Pre-treatment screening. Careful counseling and education of patient is necessary. Patient should be assessed for risk of thrombosis, and if considered necessary, anticoagulant should be given. A clinical neurological examination should be undertaken, and baseline electrophysiological testing, SNAP, should be considered. In women of childbearing potential, 2 reliable methods of contraception must be employed, commencing at least 1 month before the therapy is started. Full blood count, renal and liver function should be checked. Dose and regimen. The dose range for dermatological condition is 50 to 300 mg, taken as a single dose at bedtime to reduce the impact of sedation. Drug-drug interaction. In combination with oral contraceptive is not recommended because of increased risk of thrombosis. Monitoring. Peripheral neuropathy. It is recommended that patients are examined at monthly interval for first 3 months and then periodically, 1 to 6 monthly thereafter, for signs and symptoms of peripheral neuropathy. Electrophysiological testing should be considered every 6 months to detect the subclinical neuropathy. Laboratory tests. Pregnancy testing should be performed monthly for women of childbearing age and again 4 weeks following cessation of therapy. Full blood count liver function test should be performed monthly until dose of thalidomide is stable within 2 to 3 months. So this brings to end of this talk. It was a long talk, and thank you for patient listening. And I hope this talk will be beneficial because many of the drugs discussed today are commonly used. And thank you again, and have a